Thank you for joining us. I'm Dr. Michael Dake from Stanford University, and I'm joined today at the VEITHsymposium by Dr. Donald Reid next to me from Edinburgh, Dr. Ivo Petrov. And we were all involved in a symposium yesterday, a session at the VEITH meeting on CCSVI and its relation to multiple sclerosis. It was a very interesting session. I think we'd all agree there were about an equal number of proponents as there were skeptics, and there was a lot of emotion, but I think coming away from it, I think we can all agree that there was certainly a sustained level of interest and enthusiasm from the audience, lots of questions, and I think for patients out there and also for a number of interventionalists, this topic continues to be one that's extremely, I think, interesting and in the public's eye. So, Donald, what did you take away from yesterday at the meeting?
Well, first of all, it's a great VEITH symposium again, and the CCSVI topic continues to increase, in fact, I think, in people's interest. And that's because there's more and more data becoming available. But one of the problems, I think, is that there are some positive studies, first of all, in the diagnosis of the entity, and there are also some negative studies that don't make it easy for either the physicians or the patients to get a very firm grasp on it. And as regarding the treatment of it, the balloon angioplasty treatment called venoplasty, again, I think we're going to need to wait for 2 or 3 large randomized controlled trials to report in about 2 years' time, and then sift through that data. Very much in the same way as carotid surgery got great benefit from such trials in the 1980s, because that was very muddied water as well at the time. A lot of controversy from neurology versus the interventionalists, and I think it's a very similar problem in multiple sclerosis and CCSVI.
Yeah. I think certainly there are a lot more questions than there are answers. And I think what was apparent yesterday is that we're going to have to sort of go back, broaden our scope, back to the basic science, and start to develop this almost like a sort of a second attempt to go forward, because much of the data that we have now is difficult to make sense of. And I think it's also true that going forward, waiting for these large multi-center randomized trials is going to, again, either give us the signal to embolden us to keep studying, or maybe pull back from CCSVI. Dr. Petrov, you were talking about stem cells yesterday. You want to share with our audience some of the things
Absolutely.
from your talk?
I think that in fact the disease is multifactorial, and because of that we need multimodality treatment. The Dr. Zamboni theory did a breakthrough into the pathophysiology of the disease, and I think that there is no conflict between the vascular mechanism and the autoimmune mechanism. And for me, it's absolutely logic strategy to combine vascular restoration therapy with immune restoration and neuroregeneration therapy. So there are many trials trying to show the role of stem cells in treatment of the MS. But in fact, most of them are doing on the wrong way, the stem cells, I mean the application. Intravenously doesn't work because the filter of the lung is less than 60 microns. So the biggest part of the stem cells applied by intravenous way are retained into the lung by the microcirculation. Because of that, it's important the autologous stem cells to be applied intra-arterially in order to get directly into the target. And this was our small 11 patients trial, showing that 80% of the patients are improving after the stem cells application. And I think that combining the CCSVI opening with stem cells, it's maybe one of the most promising strategies of the future. Regarding the CCSVI, I think that as you and Donald mentioned, we need gathering more and more data, but reliable data, so gathered by experienced operators. In fact, all we are on the learning curve. Echographists, interventionalists, we are learning now how to do the procedure, how to do the diagnostics, and how to do the intervention. And I believe there is a lot of rational facts in all these fields that are awaiting.
Certainly in our study, Mike, we had an independent neurological assessment before treatment, venoplasty, not using stem cells, but with venoplasty alone, and a statistically improved outcome with neurological assessment at 6 months. That was in the group as a whole, and it was extremely significant. But the results, in fact, were variable. Some patients, as you know,
Yes.
and even though, they get a fantastic response to this, and I think it's very much driven a lot of people to continue to want to help and treat people. On the other hand, there can be some very disappointing results that you hope you've helped someone, but they actually don't seem to get benefit from it. And like Evo, I think that it rests in the detection of clinically relevant venous obstruction diagnosed by the ultrasound, and the limitations of the balloon angioplasty itself. We're not able to do this as well as I think we were in the arteries when stents came in. So that there's a whole jumble of problems still to be resolved, and I think time will probably help that, as it usually does.
Yeah, I agree. I think this is clearly much more complicated than initially recognized. It unfortunately was somewhat plagued by being played out real time in social media. And now we're starting to see patient selection is going to be key going down the line. Diagnosing of CCSVI, understanding which patients have the CCSVI to the extent that really we can judge that they will benefit from this, as opposed to that you said some don't. And again, we've sort of been gathering all of the patients together, and I think we're going to have to sort of substratify and group these into patients that we think have the best chance. But going forward is going to be very exciting, I think. I think for the audience, continued controversy here at the VEITHsymposium regarding CCSVI, another chapter, and next year we'll be back with more. I don't think this is going to go away. The people who are involved in this, in the research and clinical investigations, are still very committed, and going forward, I think we're all going to learn a lot more.